Welcome to Dynamic Station 2. Thanks for coming back and watching the next video. Since you've sat through the first one, in this one I'm going to give you a few tips. A few of the things that people forget to do is check patients' responsiveness, maintain oxygen saturations with high flow O2, and then one of the big things a lot of students will forget is checking a pulse, and if they have one when they didn't have one before, they forget to check for a blood pressure. That's 2 points. So you need to make sure that you are focusing on that. Making sure that you are treating your patient appropriately. If you see VFib, VTAC without a pulse, or anything else that can be shockable like torsades, you see it, you shock it. You defibrillate it immediately. A lot of students will forget those things. So, that being said, following up on the next video, on our dynamic cardiology video number 2, it's a little tricky. See how you feel about it. It includes AFib in a stable patient in the beginning. You might question or wonder about some of the treatments that I did. And I talk about it in the station following, but I just wanted to prelude that just a little bit.
All right. Welcome to Dynamic Cardiology. You have 10 minutes to complete the station. Do you have any questions?
I do not.
Your patient is a 55-year-old male with the chief complaint of the heart beating funny.
Okay.
He was working out in the yard and felt funny, so he came in and called 911. The patient's heart rate matches the monitor with a blood pressure of 100/70. Pulse ox is 93% on room air. Lungs are clear, equal, and bilateral. Finger stick is 80. Temperature is 99 degrees Fahrenheit. The patient does state that they are experiencing chest pain, no shortness of breath, no nausea or vomiting, and skin CTC is pink hot and diaphoretic. You may begin.
Okay, first things first, BSI, scene safe. Since my patient was complaining in the first place, I want to check if he's responsive. So, hey, are you okay? Does my patient respond to me?
Your patient is responsive and
Okay.
opens to communication with you.
I'm going to talk to my patient, ask him what is he feeling? Has he ever felt this before? He said his chest is feeling funny. While I'm speaking with him, I want to go ahead and put him on my monitor. Since he said his heart was feeling funny, I probably just want to put him on a 12 lead right away and turn my monitor on. Sir, do you have any history of any cardiac issues or anything to that effect?
Patient states no.
Okay, since I already have my blood pressure and other things, and since my patient stated he has chest pain, I wanted to do my 12 lead, which looks like it's showing AFib with a rate of 140 at this time, to rule out any signs of ischemia, acute ischemia, or any depression even in my 12 lead. Ischemia or infarct, I apologize.
No, there are no indications.
There are
of
none?
cardiac
Okay.
infarction.
Then at this time I'm going to determine that I have an idea that his chest pain is probably being caused by this acute AFib. So he said this has never happened before, so I know it's within the last 24 hours, so I'm probably going to consider giving my patient diltiazem. I'm going to start an IV. According to his blood pressure, it's at 100, so it's a little soft. I'd probably go ahead and open my IV at this time. And because he's looking a little sweaty and flushed and things like that from being outside.
You notice that your patient suddenly loses consciousness.
Okay, on my monitor I'm seeing VTAC. Does my patient have a
The
pulse?
patient does not have a pulse.
Okay, I'm going to go ahead and have someone start CPR. While they are doing CPR, I'm going to charge and shock because I saw it. So because my patient does not have a pulse, while someone is doing CPR, I'm going to go ahead and put my pads on while we are doing CPR. And then at this time, I'm going to charge and defibrillate at 200, maintaining CPR. Okay, I'm clear, you're clear, everyone is clear. I'm going to go ahead and shock. Continue CPR at this time. I'm going to drop an OPA and start bagging my patient. I want to make sure we are doing good CPR. I have my IV in place for my next round. At that time, I will probably be doing my epinephrine.
2 minutes has passed.
2 minutes has passed. I see that we have a rhythm change. I'm going to check for a pulse. Do I have a pulse?
There's no pulse.
No pulse. I have VFib on the monitor. We're going to continue CPR again. Doing CPR while I am charging for a defibrillation at 200. Okay, I'm clear, you're clear, everyone is clear. Going to go ahead and shock. All right, going to go ahead and continue CPR. At this time, I will give my milligram of epinephrine, 1 to 10,000. I can do that every 3 to 5 minutes. At this time, I can consider an advanced airway, making sure that I maintain an end tidal or a good perfusing end tidal the entire time during compressions. During this 2 minutes, I can start thinking about H's and T's as well, such as hypovolemia or hypoxia, hydrogen ions. I can look for attention pneumo, look for toxins. try to find someone who knows any type of history on my patient, and just maintaining good CPR for the next 2 minutes.
2 minutes has passed.
Okay, 2 minutes has passed. I see a change in rhythm. I'm going to check for a pulse. Do I have a pulse?
There's a pulse that matches the monitor.
Okay, I have sinus bradycardia at a rate of 40. What is my blood pressure?
Blood pressure is 70/50.
Okay, and is my patient responsive and able to follow commands? Sir, can you squeeze my hand?
No.
No. Okay, so I will start hypothermia protocols, maintaining 32 to 36 degrees Celsius. I want to give a bolus to bring up my pressure. If a fluid bolus doesn't work, I can try a dopamine or epinephrine infusion. I have my advanced airway, so I want to maintain an end tidal. I did a 12 lead in the first place to rule out ischemia, so we can still at that time go to a hospital that has cath lab or our closest hospital at that time. So I have my dopamine, I have my Ross protocols covered here. I did a 12 lead. I'm going to reassess my patient every 3 to 5 minutes due to instability and get them to a hospital as quickly as I can.
Okay, thank you.
Thank you. Okay, you just watched Dynamic Station video 2. Let's talk about how that went. Some of you might have some questions about how I treated my patient with AFib. At that time, he had a controlled rate and he was complaining of chest pain but had pretty stable vital signs. So what I did was made sure I did a 12 lead to make sure that I didn't have any ischemia or infarction, and decided that probably his chest pain was being caused by the fact that he was in AFib and it was something new for the patient. So I chose, based on my stable guidelines, according to AHA, treated him with some deltiazem. If that does not cure chest pain, then yes, go ahead and start your chest pain standing protocols. Unfortunately for my patient though, he went unconscious unresponsive. So that changed my treatment modality quite a bit. So if at any time you have a question about the stability of your patient and you want a 12 lead to decide if you need to start your chest pain standing orders or if you need to start your stable medication standing orders, ask your proctor. Now, you will not receive a 12 lead printout, but your proctor will give you information based on that 12 lead. So then at that point, they will tell you if there was ischemia or infarction, or if you have any risk factors for it being a myocardial event.